morning, everybody. Sorry that Mr. Yardley and I can't be with you today. We're in Rochester for some departmental meetings, but I wanted to leave you a message about an important topic. This is something that our Family Medicine CPC has been discussing and will be a topic we'll need to come back to over the next several months around safe ordering practices. Certainly our main goal in our practice is to meet our patients' needs, and we do that certainly through our clinical practice. We use testing and treatments and order them in an effort to monitor chronic conditions, to evaluate patients who have new symptoms, to assess risk and to prevent disease, and obviously to treat symptoms. So we need a process that balances both efficiency and effectiveness. We need to be sensitive to the time involved for providers and for our allied health staff that placing these orders creates in our electronic environment. We want to decrease the clinical burden that this process creates in an effort to prevent burnout, but we also want to create a safety culture where we know that we're providing the right test or treatment to the right patient at the right time, and to try to limit any errors and mitigate the risk that's inherent in our ordering processes. So this is an important topic. This centers around the JCAHO patient safety initiatives, so this will be an ongoing effort. So what are our options? There are really 4 best practices, and the ideal one is with computerized provider order entry, or CPOE. This is really the gold standard. There's less potential for error if the provider is entering this information in the order him or herself, but it does create more burden. So there are some instances where surrogates or delegates can be utilized, and we'll talk about that a little as we go on. Certainly proposed orders are an option. These are often for common, standardized, sometimes protocol generated orders that you're all familiar with through our panel management processes. The third option, which is frequently done, is by creating a message center note to our allied health staff. These are embedded within the EMR and saved there. This creates a virtual paper trail for review so they can be audited over time. But the message center type of order instructing staff to do things as your delegate need to have all of the elements that are in the CPOE related order. So to make sure you've correctly identified the patient, to specify the test and the indication, the associated diagnoses, and any time limitations for completion. And then finally, there are still an option for paper written orders, but these really need to be on approved forms only, and that process for approving forms is really stopped through our medical records group with the implementation of Epic. By the time Epic is here, paper forms will have been phased out. With paper orders, they need to contain patient information, have all those same required elements, have a physician or provider signature, and those are then scanned into the electronic medical record for permanent storage. So one type of order you haven't heard me mention so far are verbal orders. And unfortunately, verbal orders create risk and potentially are problematic. They're really only to be used when it's not practical for the provider to enter an order. So that's potentially when they're away out of the building in an emergency situation such as a code blue in the hospital, when there's an urgent need to modify an order for a patient safety concern. So if something was ordered in grams instead of milligrams, so that order could be clarified quickly. Those verbal orders require a readback to the provider to confirm the information for verification, but then also written authentication by the ordering provider later within the electronic environment. So with those caveats, it seems straightforward that verbal orders are very rarely needed in an outpatient non-emergent setting. And Mayo Clinic's actively focused on limiting the use of verbal orders so that we can limit errors and enhance patient safety. So let's think just for a second about what our two main contexts are for ordering. The first is in-office clinical care, and I think frankly this is the area we'll need to work on in the future. So the CPOE method of providers directly entering themselves using the approved electronic ordering form for nursing staff so they can complete procedures, give immunizations, and provide treatments in the office for patients is the ideal format. Based on our current Mayo policy, medical assistants are not authorized receivers of verbal orders to initiate these services, and while LPNs are, verbal order use creates unnecessary risk and will be phased out over the course of the next several months. So there are other things that create problems, such as writing orders on patient stickers and handing it to allied health staff, and that's certainly not an approved method for ordering. Using a paper form is not within compliance of our policies if they're not pre-approved and they're not scanned within the medical record and don't contain all those fundamental elements of a completed order. So we anticipate that this practice will be phased out over time. So these are issues that our Family Medicine CPC are continuing to review, and will be providing more guidance to the practice over time. So we certainly recognize that there'll be gradual incremental change to our practice patterns, and we appreciate your cooperation with those. Certainly the other contexts are for patients who are not here physically in our practice. So patient management certainly continues for those people when they're no longer in our presence, whether that's around pre-visit planning, during non-visit care time, which may be through patient-initiated portal messages, through phone calls, through results management as prior testing comes back, and through our triage processes. So let's talk a little bit about some specifics to consider to make ordering safer. First, any instructions to staff really need to be recorded within the medical record. So please don't print out lab results or x-ray reports and write your instructions to the staff to hand to them or to leave on their desk. That's really not within policy. For medications, we do have the opportunity for our staff to propose refills to us, but medication proposal really is not for new prescriptions. There are processes for patient safety embedded within the medical record of pop-ups and warnings regarding drug interactions and allergies and other clinical considerations that really need to be dealt with by the provider, him or herself. So best practices for providers to enter medication prescriptions directly. And then with testing, ideally test orders should be entered by providers. This helps to ensure accuracy of the ordering process to make sure what gets done is what you intended. But if you're requesting delegation of this to a surrogate, this really needs to be limited to straightforward common lab tests, such as the things that we do for chronic disease management and for health maintenance. The message center documentation that you send to the allied health staff within the message needs to contain all those components of a complete order. So the specific test, the associated diagnoses, and any time limitations for completion. We really think among the CPC members that we need to limit the ordering to those straightforward types of things, and that complex imaging such as CT or MRI or non-routine labs and potentially consultation should really all be ordered by providers to decrease the possibility for errors. So thanks for taking a few minutes to contemplate this topic. Safe ordering is really a responsibility for all of us as members of our patient's care team. So thanks for your attention and ongoing consideration of this process. And I've asked Dr. Chavez to help facilitate some discussion at the meeting today, and this is a topic that we'll continue to address over time. So again, we'll see you soon, and thanks so much for your attention today.